Hello, I'm Dr. Michael Dattoli, and I'm here to answer questions which have been prepared by the Prostate Cancer Information Group within the Greater Cincinnati and Northern Kentucky region. You at the PCIG have made a questionnaire for me comprised of 10 questions. I'd like to add just a couple before we get to those. Just because I field these questions all day long. I speak to prostate cancer patients day in, day out, and I have been doing so for over 2.5 decades. But the most common question is, how aggressive is my prostate cancer? Well, there's Gleason grading, and that can tell us an awful lot. Gleason grades go from 2 to 10. 2 is the best, 10 is the worst, 5, 6 is intermediate. Most patients tend to have Gleason 5, 6, but there's more. There's more than just the Gleason grade. What about perineural invasion within the specimen? That's an ominous finding. What about lymphatic and lymphovascular invasion within the specimen? That's also ominous. What about DNA histogram showing that you have an aneuploid tumor even though it's a Gleason 6? And here we use Prostavision, which can actually prognosticate whether a Gleason 6 is going to behave nicely or it's going to behave badly. And this is a new tool, and it's wonderful. But above and beyond that, your biopsies were done randomly. And with random biopsies, do you really know how much cancer you have? Are you confident that one of the 12 cancers came back positive and you're going to hang your hat on that and decide that you're going to be pursuing active surveillance or watchful waiting because of that? I wouldn't. I'd be concerned about bulk. And I'd be concerned that living within the cancer are more aggressive cancers that just weren't biopsied. They were missed. So there are advanced imagings which can help that tremendously. Number one, there are MRI studies. They're known as multi-parametric studies, and they include the diffuse weighting sequence studies. They include dynamic contrast enhancing MRIs. They include MRI spectroscopies, which can tell you a lot more about the volume of cancer in the disease. Not to mention, here we use colorful Doppler ultrasound, which I believe can rival all three of those and tell more about the volume of disease that you really have. Another group of patients which need to be concerned are men who have African American males who are told they have low-risk disease. We're finding that they happen to have more progressive disease than white males. Why that is, I don't know, but it is a fact. And it's being demonstrated in the clinic in patients who are just followed and pursuing active surveillance, and they progress rapidly. And it's also been demonstrated with patients go to surgery, and they initially had Gleason 5, 6 tumors, and they come out of surgery having Gleason 8 through 10 tumors, which is not an uncommon thing, by the way, with prostatectomy even in white males, but it's twofold in black males. So at this point in time, I'm really looking closely at African American males with Gleason 6 tumors or Gleason 5 tumors because they may have a beast inside that's being missed. So do your homework and don't just rely on a random biopsy, because that random biopsy may be just telling you a small piece of the picture, and you want to know the entire book. You want to see the entire gallery. Another question that patients commonly bring to me is, well, my surgeon told me I'm too young and I should have surgery. There's absolutely no basis for this. There's absolutely no data to support it. Not to mention, most patients who have surgery, and today Da Vinci robotic surgery, fail and have to undergo radiation anyway, and then get the worst of both worlds and have to live with some degree of incontinence, be it flagrant incontinence or stress incontinence, sexual dysfunction for not 10 or 15 years, but 40 or 50 years in a patient who's 40 years of age, 42 years of age. I'm commonly seeing 30 and 40-year-olds. The pendulum has swung down, and we're seeing so many more men of all ages that I'm now considering this a disease of all ages. And if you speak to other practitioners who specialize in prostate cancer, you're going to find that they're seeing the same thing and saying the same thing. They're just seeing so many younger patients. And these younger patients often harbor very aggressive cancers. Not always, but most of the time I'm finding this to be the case. They're also told that if you have radiation, you can never have surgery. This is another myth and simple scare tactic. You can have surgery, probably wouldn't opt for it, but you can have surgery, and I know many surgeons who would do surgery. In fact, Duke Medical Center right now has an ongoing trial whereby they're utilizing preoperative, also called neoadjuvant, radiation prior to performing surgery. So they give neoadjuvant or pre-surgical radiation and then 8 weeks later perform surgery. Can't be that difficult. The study is not demonstrating any significant statistical problems with the patients undergoing the surgery. So this notion that you can't ever go back and salvage or rescue a patient with surgery is absolutely false. And again, there are other options out there that you may wish to select. Radiation, and cryosurgical, and there'll be others coming down the road, and there are many more. But the reality of it is you can have surgery after radiation. Okay, so under question number 2, how do you obtain most of your patients? Well, the answer to that question is word of mouth, but it's also the fact that patients who are really into researching who has what, who has the best results in terms of outcomes, who has the least amount of side effects, who developed seeding, who developed things called DART, which is a form of external radiation, they end up coming here because we have published data. I've written medical textbooks. And this is very important to patients who do their research and do their homework. And our patients do their research and their homework, or perhaps their family members do. But that's a good portion of our patients to come here from that perspective. The next question is, do you have significant marketing expenses? Yes, I always think they're significant, perhaps too much, because again, most of our patients don't come from our marketing. They come from research and word of mouth and just how good we do with our prostate cancer patients, especially patients having intermediate to high risk features, the patients that others really don't want to deal with. Okay, question number 3. You and Dr. Charles Myers have a long history together. What are the significant connections? Well, recognize that long ago, when Dr. Myers was the chief of research at the National Cancer Institute, we would often speak alongside one another at different conventions and conferences. The same when he was the chairman of the University of Virginia. And I came to listen to what he had to say, and he had created some of the original agents for prostate cancer in their advanced form. Meanwhile, he came to hear what I was talking about, and that was treating patients with prostate cancer outside of the scope of the standard of care, treating patients who had bony lesions, documented biopsy-proven bony lesions, patients who had documented nodal disease, and I would treat them. And I was finding that these patients were doing well. To this day, I find patients who I've treated 25 years ago who've had bony lesions and lymph node disease who come to see me, and their PSAs are completely undetectable, and the patients have lived high quality of lives. But lo and behold, Dr. Myers himself was diagnosed having prostate cancer at a young age. He never bothered to have his PSA checked, but when he did, he came to find that it was high, greater than 20. He had a high Gleason score. He had lymph node involvement. He had bone marrow invasion. So he was in the highest risk category, outside of the standard of care, outside of the box. So he opted to be treated by myself. And I did treat him, and I'm very glad I did treat him in the most aggressive way I know how, because today he is completely free of disease and enjoys a high quality of life, as many of you know. The next question that you have for me is, how do you determine the supervisory role split for a patient's prescriptions and supplements pre and post Dattoli treatment? Best I can tell you is it just works out. Dr. Myers and I are on the same page. We think alike. I have the utmost respect for him with respect to his systemic management of patients for prostate cancer. I don't believe there's anyone better. I believe he has the utmost respect for me with respect to local regional care of patients having prostate cancer. So if a patient comes to me and I believe he should be seeing Dr. Myers, I'm going to send the patient to Dr. Myers. If a patient comes to Dr. Myers and he thinks he first should be seeing me, the patient's going to see me. Within the realm of what I do, our first-line hormonal regimens are similar, if not the same. And so I will prescribe those agents for the patients, and we will deliver them during the patient's care here at the Dattoli Cancer Center. At some level, however, if a patient has extreme features, I'll send him back to Dr. Myers, and I think that he should always be in your corner. I know of no oncologist as sharp as Dr. Myers and who thinks so outside the box. So we really do have a complementary role, and we think alike, and we have similar supplements, although I would still say he's the guru of diet and supplements in general. I'm now looking at question number 4. You and Dr. Gerald Sharkey have debated publicly over separate versus combined ownership of prostate oncology and urology practices. What is the issue, and what is your position? Well, first let me say, I've since spoken to Dr. Sharkey and won him over. He agrees with me. So there was an article, I think, that you're referring to, which was in PACT, and the next one was written by Dr. Sharkey. However, we got together and spoke about it. He didn't really know what was truly going on with this so-called URAD situation. This is a very ugly part of medicine, especially within the framework of prostate cancer. To break it down, in 1992, there was a Stark Law. And the Stark Law basically stated that you would keep within your practice. You would practice medicine under your roof and deliver the treatments that you deliver under your roof. There shouldn't be any self-referring, and there certainly shouldn't be a kickback. In other words, if I were to send a patient to a specific doctor because that doctor is going to reward me financially, that's an ugly situation, and it's called a self-referral. This self-referral became very popular, and this is the reason why the Stark Law was passed. However, in 1994, there was an amendment, and the reason why there was an amendment was because it became known that, well, you know, if you're an oncologist treating patients, you need to know what the patient's blood counts are doing. You need to be following their CBCs or CMPs or, you know, their panels. You need to know if they need transfusions and such. So it would be to the patient and doctor's benefit to have a laboratory on site to do that. It would certainly be to the patient's benefit for a cardiologist to have a stress test and an EKG in his office and not be considered self-referring those machineries. It would certainly be to the patient and doctor's benefit if an orthopedist was able to take x-rays and look to see if you had a fracture of your bone versus just some traumatic injury. Because of the fact that radiation was in the language of the Stark Law 2 in 1994 as an exemption, the urologists have taken it to another level. They've actually purchased radiation centers. They own radiation centers. They refer patients to their own radiation centers. So there's a financial incentive. They were not trained in radiation. So as you can see, I'm quite opposed to this concept of ownership of prostate oncology by urologists and urology practices. I think it's shameful. And in fact, what you should do is Google the word PIMA, P-I-M-A. P as in Peter, I, M as in Michael, A as in Anthony, and also Astro, A-S-T-R-O. And what you're going to find is what Congress is talking about today. And under the ruling of Congresswoman Jackie Speier, they're looking at this very closely, especially since there have been 2 GAO studies. These studies are accountability studies. Government Accountability Office is what GAO stands for. And what they're looking to find is, are these practices, these Eurorad practices, overutilizing radiation? What they've come to find is yes, 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 by hundreds and hundreds of millions of dollars. So this is a hot topic, and as I say, if you just Google those words, you're going to see how hot it is, with Congresswoman Speier leading the show. And hopefully this is going to be overturned in a very short period of time. In fact, within the body of that article that you'll read, they even refer to these as money-making schemes. So I told you that Dr. Sharkey, he agrees with me now. He really agrees with me now after these 2 GAO studies have demonstrated the complete overutilization. And it doesn't stop with radiation. They've now taken pathologists and put them in their office. And the pathologists are doing reads. Now, pathology can be a very tricky thing. There can be a gray zone between a cancer and a non-cancer. But if you have a pathologist on site who's going to benefit, and the urologists are going to benefit by that patient being told he has cancer, well, it's a subjective call, so he can say it's cancer. Patient's now treated. This is why we're spending hundreds of millions of dollars in overutilization, primarily with IMRT. I can tell you a very interesting story. I was in the operating room one day and doing 5, 6 seed implantations. I then went to the surgical lounge, and there was a urologist there, and I knew he was involved in one of these Eurorad schemes. He said to me, "I'm curious, why are you doing 5 brachytherapy cases, seed implantation cases?" And I told him, because it works. And he said, "Well, that's interesting, because while I'm here doing bladder tucks and using shock waves to kidney stones, I have patients being treated at the same time. I don't really want to waste my time doing seeding." That has actually become so prevalent that they've actually are resetting the standard of care. I spoke to an insurance carrier recently, and they said that they're no longer covering seed implants, even though seed implants have been demonstrated to have the highest cure rates, bar none. So this is how powerful and influential the urologists have become, and their pockets have gotten deeper, and their lobbyists are big and huge. And it's going to be a dogfight. But I hope we prevail, because it is definitely not to the patient's interest. Moving on to question 5. Are most of your patients facing initial treatment or treatment due to recurrent disease? It's really 50-50 at this point in time. The second question under number 5 is, are more of your recurrent patients surgery or radiation failures? Clearly, it's recurrent patients secondary to surgical failures, especially since the Da Vinci robot became in vogue and is being used by 90% of the urologists in the country. Question number 6. One of your patients and PCIG member understands your color flow Doppler is more precise and informative than any color flow Doppler available elsewhere. Is this true? Yes, it is true. We have a very unique Hitachi high vision, three-dimensional, real-time three-dimensional color flow Doppler ultrasound. It enables us to see so much more than with your standard color flow Doppler ultrasound. Here we've always had color flow Doppler ultrasound, so we've been going from generation to generation to generation, but they've gotten better, and today with this Beta-Site machine, it's second to none. The second question under number 6 is, if this is true, is this improvement protected by patents or trade secrets? Honestly, I don't know from Hitachi. What I do know is that What this machine also allows us to do is elastography. This is a new way of finding prostate cancers for biopsy, or following prostate cancers and determining if there is recurrence using an ultrasound. That I do know is trademarked. It's branded. Third question, number 6, and what exactly is more precise and informative? Well, recognize that ultrasounds use frequencies. They bounce their waves off of tissues. Our ultrasounds from Hitachi and our specific ultrasound that we're using today has special tissue harmonics. It also enables us to change the gradient of the tissue harmonics. This is novel, this is new, this is second to none. We're able to narrow the ultrasound beam and remove the side lobe artifacts, and by doing that we're able to detail the cancer, we're able to detail the capsule of the prostate to a much greater degree. I'll go so far as to say that to a degree that's far higher than even an MRI. Question number 7, is ferriheme only a lymph node imaging agent? No, actually it's primarily used for patients who are undergoing dialysis. The second question under number 7, has the ferriheme testing been a great breakthrough for prostate cancer treatment, especially for recurrent disease? Absolutely. To me, it is the greatest breakthrough in diagnostics for prostate cancer than any other test ever. I worked alongside Dr. Sodhi with the Prostate study, and he did a great job. May he rest in peace. After Dr. Sodhi, there was really no one that I could rely on. But I have been working alongside of others who have been involved with nanoparticles, and this dates back to Sloan Kettering when we were working with Harvard and Dr. Haringsani and with nanoparticle technologies, which eventually I was working with Dr. Berends at the University of Nijmegen in the Netherlands when we didn't get FDA approval, which was quite a disappointment to me. Recognize that because of the ability of ferriheme or ferramoxetol, which we had identified to be very similar to Combidex, by the way. It has a very similar organic chemical structure and very similar biokinetics, that we were confident that this was going to work. Yes, it's used as a treatment for dialysis patients, but we have found that it's used for prostate cancer surpasses anything we've known. And the group in Orlando is doing such a tremendous job that they have surpassed every one that I've used previously, and they fuse their information with my center. So I've treated a lot of lymph nodes. If so, when will it be allowed wider use? That's a very difficult question to answer. Again, it all started back in 1990, and it went to the FDA in 2003, 2004, and did not become FDA approved. There are some reasons, and there were some shortcomings on behalf of the company that was selected to present this to the FDA. Be that as it may, we are fortunate to have identified ferramoxetol or ferriheme as we're identifying it to be the same as Combidex, and we're with the group at Sand Lake Imaging in Orlando. They're just doing a tremendous job, and they're helping me identify patients who have lymph node disease where I would not otherwise know. Although I know quite a bit about lymph node disease now, having lived through the era of Prostate with Dr. Sodhi, who was second to none, may he rest in peace, and I've never had anyone else do such a great job with Prostate. But the nanoparticle technology is out of the box. It's just in another world, and it's the future. Question number 8. You are purported to be king of lymph node disease. What is your worldview of lymph nodes? Why is it that female patients who have breast cancer and lymph node disease, why are they offered curative treatment? Why is it that patients who have colorectal cancer, lymph node disease, offered curative treatment? Why is it that patients with head and neck cancer and lymph node disease offer curative treatment? Why is it that patients who have lymph node disease and prostate cancer dismissed, written off until they have incurable disease by the urologists? It's not true. Prostate cancer perhaps is the best disease to be treating lymph nodes. It has a methodical pathway. And yes, I do consider myself the king of lymph node disease, as I've been living and breathing it since 1990, lymph nodes and where they live and how they go away with treatment. And we have a great way of treating lymph nodes with DART, which was developed at the center. It's an extremely precise radiation modality. You couldn't treat lymph nodes up into the abdomen or even into the lower abdomen or upper pelvis with IMRT, with IGRT, with sophisticated ways of treating cancer. You couldn't do it. Patients would become ill. They would be nauseated, vomiting, having diarrhea. We're just not seeing that. When we get into the abdomen, we may have a little bit of nausea, but we can treat up to the diaphragm. We've treated up to the neck with lymph nodes, and we've had an impact on these patients. An impact where the disease is placed into a remission. Some patients, the cancer has not come back at all, or in some patients, we could manage them with supplements. This is something we never had before, we've never seen before. We've taken a tiger and made a pussycat out of it. And if we hadn't treated those lymph nodes would have sat there. And to me, the lymph nodes are one and the same with the prostate, because the prostate is the fire. That's where the fire started and has the malignant clonogens. But the lymph nodes are really the same. I mean, they're just a confluence of the prostate. So now that you've identified that this patient has lymph nodes in the pelvis and the abdomen or wherever, what do you do about it? Well, here we use DART. It's a very sophisticated form of radiation. We developed DART here. And in a very simple form, it's basically a treatment which you could actually hit something the size of a dot, the tip of a pen, from that's within you from the outside. So we can shoot microbeams at these dots, which we call voxels. And obviously there's going to be thousands of microbeams and thousands of voxels. But at the end of the day, we're going to be able to target exactly where those dots are, where those voxels are, with our DART, with the microbeams. And there'll be thousands of them converging at different locations and missing, and this is critical, missing the important structures, the non-cancerous structures. This is the reason why only DART can be used to treat these lymph nodes. IMRT can't do it, IGRT can't do it, certainly CyberKnife can't do it, protons can't do it. I have a lot of experience with protons. My experience dates back to the 1970s when I worked at the Harvard cyclotron with Dr. Munzenreiter on proton therapy. And let me tell you, proton therapy is a good therapy, but it's a good therapy for tiny tumors of the brain. So is perhaps CyberKnife or stereotactic radiotherapy. But the reality is, when you start increasing the size of the tumor, the advantages of protons become distinct disadvantages. And many people have the notion that the proton just travels through, leaves no energy, doesn't touch anything except for the cancer, and then leaves and doesn't touch anything else but the cancer. That is a myth, that is an untruth. The reality of it is the entry dose with protons is enormous. And that's why patients get these risks of having hip fractures, because the dose of the hips is really enormous. Meanwhile, with CyberKnife, you're getting a very high dose at once. We call that hypofractionated radiation, which means that if you move a millimeter, and they don't have all the four-dimensional, the array of four-dimensional technologies that we have to deliver DART, and you're going to move a millimeter. And what's going to happen is the normal tissues are going to get these very high doses. You won't know it now. You won't know it 3 years from now. It'll take 5 to 10 years before damage to the surrounding tissues, which, by the way, are critical ones. The rectum, the bladder, the urethra, critical things, neurovascular bundles that innervate the penis. So I really have a problem with protons and CyberKnife. I give talks, I give lectures which go on for hours for each of those. But I would like to say that even for the treatment of prostate cancer proper, without treating a whole lot of lymph nodes, I would much prefer to use DART than I would protons or especially CyberKnife, as they have tremendous shortcomings. So you have to treat those lymph nodes. You have to treat them to a definitive dose, to a curative dose, and by doing that, you get rid of that element, that badness associated with the cancer. And so you really do change the radiobiology of the disease. Even if you don't cure the patient, you're still going to change the radiobiology of the disease. Probably not in every patient, no, but in the majority of patients, you are going to do one of two things. You're going to eradicate all the disease, and they're never going to have to be treated again, or you're going to change the radiobiology, where you're going to do many things. You can treat them maybe with supplements. You could maybe slow down the progress of their cancer with simple hormonal regimens, and the patients may never become androgen dependent, or you may prolong the period before they become castration independent. What is your final question under 8 is, what is your plan of attack? Question. Well, what I ultimately believe is that using radiation coupled with systemic therapies, that prostate cancer can now be approached like other cancers, like breast cancer, like colorectal cancer, like head and neck cancer. We can integrate. We can use differing hormonal therapies. We can combine them with radiation. We can find where the cancers are by using USPIOs. Ultra small supraparamagnetic ferrous oxide nanoparticle test. This is its formal name, and we refer to it as USPIO. But that is what is done in Orlando. We could also use information from PET scans and F18 whole body sodium fluoride PET bone scans to identify bony lesions. And we've taken on patients having bony lesions, and we've done this with success. And again, we've taken the tiger and made a pussycat out of it. Have we cured the patients? Maybe not. But we've really put a dent in the cancer, and it's acting far less aggressively. It's behaving nicely, so to speak, if a cancer can behave nicely. But it is. And again, if you can stop something with, or let me not say stop it, if you can slow the progression with simple complementary supplements, you've made a tremendous impact for that patient. With respect to question 8 and the plan of attack, and using systemic agents, nanoparticles and such, I think that cancers are going to really dislike nanoparticle technology, because cancers tend to put up this blood tissue barrier, and yet cancers are very vascular. And so this is a site that cancers can be attacked by nanoparticles because they're so small. They're a millionth of a millimeter. They're going to enter into the capillaries. They're going to enter into the infrastructure of the cancer and ablate it. Okay, they're going to stick there. And there's going to be a time when we're going to be able to label these nanoparticles and send them with cytotoxic chemotherapy agents, send them with cytotoxic radioisotopes to select areas and eliminate them. Question number 9. As a clinic in Georgia uses a similar treatment process of radiation seeds, but inserts the seeds first before the external beam, why do you do the opposite and radiate first, then followed by seeds? Think about this. If my palm was your prostate, if my fingers were the anchors or roots or tentacles leading the prostate, what am I more concerned about? I'm more concerned about those fingers. So the concept of seeding the palm first and leaving the fingers alone, I don't like. In fact, if you look into the archives of brachytherapy, you always use radiation first because you draw those fingers back into a fist. Now you have an epicenter. Now you use your high-dose brachytherapy to eradicate the tumor. So that makes sense to me. Do you agree with the process as they seem to publish treatment results that are similar to yours? I'm sorry to say, but I'm really going to take issue with this. Even Dr. Chodak from the University of Chicago reviewed the paper from Atlanta, and what he identified was that they diluted their data by incorporating patients who had low-risk features and into their data analysis and into their ultimate cure rate. That waters down the data, and it makes things all look better. But if you were to dissect it into intermediate and high risk, you're going to find a tremendous difference between what I do and what they do in Atlanta. For example, I've published data on intermediate disease as being 89%. In Atlanta, it's 74%. I've identified that with intermediate disease, if you have a negative PAP, that it's over 90%. Let's talk about high-risk disease. I've identified that with patients having high-risk disease, these are aggressive cancers, and if you read into my papers, you'll recognize that my high-risk patients are really high risk. They have most of them have virtually all the risk factors, namely really high PSAs, really high Gleason scores, just really high volume disease, lymph node involvement, all kinds of bad things. And yet we've reported 72% cure rates. In Atlanta, they report 44%. So there's a great disparity. So the data is not similar. Again, even Dr. Chodak in his review in the same journal that this was published states that the data was watered down by putting into place patients who have low-risk features. And by doing that, it just makes the data look all that much better. If I did the same, yeah, my numbers would go up too. I mean, overall, when I combine intermediate and high risk, I have 82%. If I included low-risk disease, it would be up into the 90+%, easily. So it's apples and oranges, and that's just the way I see it, and that's not only the way I see it, that's a fact. The data speaks for itself. Go back and read the papers. There are a few additional reasons why I really think that our data is superior to Atlanta's when you look at the intermediate and high-risk groupings. Number one is that they do not treat lymph nodes, and it is imperative to treat lymph nodes in these patients. If you look at their brochures, I have seen their actual data. They do not treat lymph nodes. They treat a margin around the prostate. That's not enough. That's not getting to the obturators and external iliacs and iliac lymph nodes, which we have to treat in those patients because they're typically affected either grossly or microscopically, but they don't treat them, and that's a problem. Let's talk about high-risk patients, extreme high-risk patients, and believe me, I am not a hormone bug. I do not like to give hormones. I try to stay away from them with my patients, but there are select patients that really need hormones, and one group of them is the high-risk patients. These are patients where they have, Gleason 10 tumors or Gleason 8 through 10s. They have PSAs over 20, and there's a lot of bad things associated with their cancers. These patients need hormones, and there is a mountain of data suggesting from controlled trials, from the RTOG, from SWOG, EORTC, demonstrating that these patients really do benefit substantially when given hormones. There is a synergistic effect that 1 + 1 radiation and hormones doesn't equal 2, it equals 3 or 4 or 5, and we really look to exploit that effect. They do not. So that could explain to a great degree why especially our high-risk patients do so much better than their high-risk patients. And another rationale for the use of hormones is downsizing a patient's prostate. Recognize that many patients come in having very large glands. Well, again, I'm not a hormone bug, but if they have really large glands, we have to shrink them down, and the best way to do that is with hormones. And we'll do it as briefly as we can just to get them to the point where their glands are small enough that they will have a comfortable implant. If you don't do it, you're going to make them miserable. And so you really want to give hormones for downsizing of the prostate. You really want to give hormones to those high-risk patients because they're going to do better, and I do believe that's just another reason why our data is better than Atlanta's. And putting it all together, I think these are the reasons why our data is superior to Atlanta's when you're looking at intermediate and high-risk groups. Again, they've piled in there a lot of low-risk groups to get a overall survival, but when you break out and sub-select the groups from intermediate to high risk, there is a great disparity, and we win on that point. From 15 to upwards of 30%, though they having only a 44% cure rate with high-risk disease, and we have published a 72% cure rate. So this is quite disparate, and if you don't have an elevated PAP, then our numbers are even superior. So there's this disparity. So there's this discrepancy in data, as I pointed out, and as Dr. Chodek pointed out in the same journal article that the Atlanta group had published in. So why am I doing better? I think I'm doing better because I historically have put seeds outside the prostate cancer. I was the first to do that, to put seeds outside the prostate gland, let alone the cancers. I put high radioactive seeds within the cancers themselves. So I mix and match. I don't use a same radioisotope dose strength per seed, per cancer, per entire prostate. I mix and match. If there's a cancer, it's going to get a higher energy seed. If it's next to a critical organ, it's going to get a lower energy seed. But I'll never not address the cancer properly. But I'll also put those seeds outside the prostate capsule, and that's unique, and you can only do it with the type of seed that I use, TheraSeed, because of its concave ends. And I recognize this early on, and in fact, every other seed is concave, and they migrate and move around, and your urologist will tell you, no, don't do brachytherapy, it's going to migrate and move around. My seeds do not migrate and move around. The fact is they have concave ends, and what that means, they have inserts, and the tissue can go inside of each side of the seed, and I twirl it, and the seeds are there for life, and they're tissue compatible, and they stay there, and you never have to disclose it. They're non-ferromagnetic, so if you need an MRI of your hip or such, you don't even have to say you have, they'll ask you if you have metallic parts. You don't have to say you have any metallic parts in you. So I've given you this information about the hand situation and why I'd much prefer that to happen. If you were to go into the archives of brachytherapy, you're going to see that's how it's done in all cases. Women having cervix cancer is probably the closest you're going to find to prostate cancer. It lives in the same area, and you always use external beam radiation to draw the cancer back and close to your brachytherapy elements. Patients who have tongue malignancies, base of tongue malignancies, I've done hundreds of those at Sloan Kettering. We would always take advantage of external beam radiation to shrink down the tongue malignancy and the lymph nodes, and then boost the primary tumor with the brachytherapy. So it makes eminent sense to always use external beam first and then target the tumor with brachytherapy. Question number 10. In 2009, you published a Dattoli Blue Ribbon Prostate Cancer Solution. This excellent handbook compared treatments in detail, among other teachings. What three statements need significant revision now 4 years later? Well, here is our Dattoli Blue Ribbon Handbook, Prostate Guide, and that was 2009 copyrighted, and in 2012 we had the Dattoli Challenge with many updates. But let me just say that we've never stopped upgrading our computer software. We've never stopped upgrading all of the things we do here to such a high level. I've already talked about our colorful Doppler ultrasound, but it transcends through all the technologies in this building, from the third generation sonar arrays to the third generation cone beam tomographies and respiratory gating and portal vision and portal imaging, and all the things that we do here and continually upgrade. we now have more knowledge about the Da Vinci robot. This was something that no one knew before. It was new, it was novel. The urologist would tell you be in and out of the hospital in a couple days, minimal blood loss. Well, now the data is maturing, and as it matures, the ugliness is coming out about the Da Vinci robot. And I'm sorry to say that because many of you may have had that procedure. Be that as it may, the longer term data is demonstrating that there's a threefold increase in failure compared to conventional radical retropubic prostatectomy. There is a 25% risk of increased risk of incontinence using the Da Vinci robot over time. There's already a pretty high risk for incontinence with radical retropubic, so add 25% to that. There's a 25% increased risk of erectile dysfunction. There's already a pretty high risk. So this data, as it emerges, is starting to challenge the gold standard, which many will tell you is the Da Vinci robot, but no more. If you read into the urology textbooks, they're more talking about retropubic radical prostatectomy, the way they used to do it, and removing more lymph nodes. You can't remove more than 2 to 4 lymph nodes using the Da Vinci robot. I see so many cases where the Da Vinci robot doesn't remove any lymph nodes at all. Also, we've gotten into a more integrative approach with prostate cancer. So, and let me speak more to the high-risk disease, because with high-risk disease, we're going to be using hormonal agents, but we're also going to be wanting to mitigate some of the side effects that we know hormonal agents give you. For example, hormonal agents give you hot flashes. Okay, so we use estradiol patches, and it works. It takes down the hot flashes. Interestingly, it also has its own pathway for killing cancer cells, so it's a twofer. Hormonal agents weaken your bones. The estradiol patches strengthen your bones. Again, more benefit, less detriment by using additional agents. Many people think when they come to the Dattoli Cancer Center and we talk about more comprehensive hormonal regimens that it's going to be even worse than what they heard from their friend who's just getting unopposed Lupron. Not so. We've integrated other types of agents. I've talked about estradiol patches. There's something called cabergoline or Dostinex. It's a very interesting agent. It's not a hormone, but what it does do is it mitigates breast swelling and breast tenderness, and it has its own pathway for killing prostate cancer cells. Bisphosphonates are another group of agents that we commonly use, and they strengthen bones that hormones weaken, and they too have their own pathway for killing prostate cancer cells. So a lot of the comprehensive package is made up of agents which mitigate the side effects of hormones. So we feel we're doing an excellent job at that, and this is something we weren't doing 10 to 20 years ago, just like we weren't doing DART 20 years ago. DART, by the way, has been a 20-year evolution, and so have a lot of these integrative medicines. And we also use complementary supplements in patients. And we don't just go with the press. A recent article about omega-3 fish oil, a terrible study. There are hundreds of other articles extolling the benefits of omega-3, and it's a shame that that article got such traction. But we do try to use data which is solid and strong, and we use these supplements on patients for their benefit, for the detriment of the cancer, and it works. And it also helps to revive patients using antioxidants and multivitamins of different sorts after a treatment course, which can be rigorous when you're using DART and seeding and hormonal therapies. Multimodality treatments of any kind are rigorous. And after treatment, we're going to want to reinstate things. We have ways of improving erectile function after being on hormones, using low doses of PD-5 inhibitors for a period of time. And we're watching this using using our colorful Doppler ultrasound, which also gives us the ability to track, it's called duplex study, tracking penile arteries and how they're working, what they're doing, what the velocities, if there's insufficiency or regurgitation. We're finding that we can fix this. We're finding that it can improve over time by using low doses of PD-5 inhibitors and other agents that we use here. So the integration of other agents in addition to the radiation regimen alone has made a tremendous benefit. And brachytherapy also carries its sundry of side effects, and we've really mastered that. We know when it peaks, we know when it troughs, and we give you the right agents as you're peaking, and we know when you're going to be better. And if things aren't working that way, we know something's wrong. Integrating our treatment with other medicines has become a very important part of this program, and I believe has become a very important part of our success and cure. Continuing with number 10, 3 statements. I've given you a couple. Certainly, I've already talked about the nanoparticle technology, which I believe will ultimately take over medicine. It's going to be called nanomedicine. And there are just so many other agents that have come down the pike in the last 2 to 3 years. Abiraterone, Zytiga, Xtandi. These agents just keep popping up. We have vaccines such as Provenge, and more work is being done along the lines of vaccine therapies. My expectation is that it's going to continue to go. It's going to continue to go to the point where you really don't want to write off a patient, because much like the lady with her breast cancer who you treat for cure even when her disease spreads, or a cervix cancer when her disease spreads, or when a man or woman when their colorectal cancer disease spreads and you end up resecting a liver metastases aggressively or removing a lung tumor aggressively, we feel the same way about prostate cancer, that it should be attacked aggressively. And by doing this, you're bringing in that armamentarium. You're using all these other agents, and there are going to be more. And right now, again, I'm the local regional guy, and I'm gonna do my best with DART, and in either a post-operative setting if you've been treated with radiation before, or you've been treated with surgery and need radiation, or initially with DART alone or DART and seeding, which I do prefer initially for patients, especially patients having high risk features or even intermediate risk features. But we're just going to continue moving on, and what the future holds, I don't know, but I do believe it's going to be better, and it's going to result in cure for many more patients than ever before. Okay, question number 11, political one. How will Obamacare change medicine in our country? I'll read the entire statement. What major changes do you see coming to prostate cancer treatment in the United States? In my opinion, medicine is going to change dramatically for the worse. We're already seeing it. We're being challenged. We're needing to get pre-certification for delivering brachytherapy, for giving Xgeva, for delivering DART. And we're being denied treatment for prostate cancer patients. The Obama administration thinks that they can throw on 30 million more people into the healthcare bin and somehow it's all going to work out. It's not. They got to ration care. And, if you're 55 years or 50 years or greater, beware, because they're going to ration care. We're already seeing it. As I say, I speak to both doctors and bureaucrats, more and more bureaucrats. The doctors are kind of told what to do. They're basically hired guns to shoot you down and tell you that you don't need this therapy, or that patient is not going to get the therapy and we're denying it. But more and more, you're not going to be getting what the doctor ordered. You're going to be getting what the government bureaucrat ordered. The bean counters are going to tell you what therapy you're ultimately going to get. It has to go that way. It has to go the way of Canada and Europe in order to make ends meet. And I don't think the ends will ever meet, to be frank, here in the United States, and will always be imperiled with dramatic rising costs in healthcare, just because we're all so used to it. It may take a long time, but the reality of it is we are seeing it today. We've already had reimbursement cuts in Medicare upwards of 30% in everything that I've mentioned. We've had 100% cuts in many of the instruments we use for DART. And mind you, we have to pay on a yearly basis monies to keep those instruments alive and working. This is taking a toll on us, but we continue to persist because we want to deliver the best radiation in the world. But what will be the future in terms of the best radiation in the world? I don't know. What are we going to be allowed to do? I don't know. If you're 60 or 65 and you have prostate cancer, what's going to happen? Are they going to just tell you, sorry, no, nothing we can do? That's what they are told, by the way, in socialized countries, and that's why we treat so many people from Canada and Europe. They come here because they can't even get treatment there, even if they want to pay for it. They cannot get it. So this is what I foresee with prostate cancer, especially prostate cancer. Look at what the task force has already done. They've already said you don't need a PSA. Do you think that wasn't political? It was very political. And here you have the most common disease, common cancer in humans aside from skin cancer, afflicting 240,000 men annually, killing over 30,000 men, and there's 2.5 million survivors who are potentially can fall down into the same bin of death. To summarize, what I really think is going on is there's an agenda, and the agenda is to break the backs of both the physicians and the hospitals in the United States to the point where they're going to need to be bailed out, and to a point where they're going to be nationalized, and we're going to have national health care. That's what I believe is the agenda of Obamacare. Based on these questions and my answers, and if you have any burning questions, feel free to email us at the Dattoli Cancer Center, and we'll give you our best in terms of what we think the right answer is. Thank you again.